welcome to our Congressional Biomedical Research Caucus briefing. I know it's a full room. If you can't find a seat out back, there are some seats out front. And don't be offended, don't worry if you have to get up and leave early. I'm speaking for Dr. Boult, but I'm sure he's not going to be offended if you have to go. So let me introduce to you Dr. Chad Boult. He is the Eugene and Mildred Lipitz Professor of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. He directs the Center for Integrated Health Centers, Healthcare, and holds joint appointments on the faculties of Johns Hopkins University Schools of Medicine and Nursing. He's been geriatrician for more than 20 years and has extensive experience in developing, testing, evaluating, and diffusing new models of healthcare programs for older persons. His current research includes guided care. It's a novel multidisciplinary model of primary care for older people with multiple chronic conditions. Guided care, which you will hear more about today, is designed to improve the quality and outcomes of complex health care by improving the delivery system's design, decision support, access to clinical information, and support for self-management, and by facilitating patients' access to community services. He's an expert on chronic care and speaks frequently at meetings and conferences across the country and abroad. He is an author of a new book. It is new, correct? A new book. Is this it? Guided Care? This is it. He'll probably show you during his speech, but I'm again jumping into the punch. So without further ado, I'd like to bring up today's speaker, Dr. Chad Boult.
Thank you. Thanks very much, and thanks to all of you for coming. I appreciate the opportunity to speak with you for a few minutes today. As you heard, I'm a geriatrician, a specialist in the care of older people, and I've spent the last 20 years studying ways that we can actually improve our healthcare delivery system to improve the effectiveness and the efficiency of that system in the care of older people. And particularly what I'm going to talk to you today about is our latest model, which is focused on the older person who has multiple chronic problems. You're probably aware that this is the population that is the least well served in our Medicare population. This is the 20% that spends 80% of the Medicare dollars. So this is our target population, and I'm going to tell you today about the model that we've developed. It's developed by an interdisciplinary team at Johns Hopkins. Tell you a bit about how it works and some of the results that we've seen from our studies that we've done of this model. And I'll finish up with a description of some of the efforts that we've been making lately to make this model available to those who are interested in healthcare reform, which I'm sure all of you are today. But it is a model that we're making available. I should, by way of I guess it's a non-disclosure, we have no commercial interest. We're not selling anything, basically. We're academics. So we've developed this model, making it available to the Medicare program. And I'll tell you about the various forms of assistance that we've developed to help disseminate this model across the country. Excuse me a second. Now, to get started, I think it's a good idea to illustrate the kind of person for whom this model is developed. I've said it's an older person with multiple chronic problems, but let me introduce to you a patient, Mrs. Marion Chen. Mrs. Chen is a 79-year-old widow, a retired school teacher who now lives alone. She gets by on a modest income from her Social Security, her teacher's pension, and she has fee-for-service Medicare. She has, fortunately, a daughter who's devoted, lives only 10 miles away, but is raising 3 teenagers of her own, has a husband and a job, and a very full plate. Mrs. Chen has 5 chronic conditions, kind of the usual conditions that affect older people. She sees 3 physicians regularly, a primary doctor and 2 specialists, and then she sees others as needed. And she takes 8 prescription medications every day in divided doses. So this is a typical older person who has multiple chronic problems, not an exaggerated situation at all. Let me walk you through the experiences of Mrs. Chen in the past year. I'll try to talk loudly enough so you can hear without the microphone and I can point. In the past year, her chronic conditions have flared up, resulting in 3 hospital admissions, followed by a total of 6 weeks of subacute rehab in 2 different nursing homes, followed by a total of 5 months of home care from 2 different home care agencies. She was referred to 6 different community agencies, filled 22 prescriptions of her 8 medications, and had 19 outpatient visits to various providers. All in all, in this year, she's seen 8 physicians, 6 social workers, 5 physical therapists, 4 occupational therapists, and 37 nurses. So is it any surprise that care is a bit fragmented and difficult for people like Mrs. Chen? She's confused by all this, all the care, all the medicines, everything she has to do. She rates the quality of her life as poor because of all the medicalization and the fact that she has these diseases. And she, despite having fee-for-service Medicare, which really only pays about half of her costs, so she's paying the other half out of pocket. Actually, she and her daughter are. Her daughter, you see here, the picture tells the story. She's a bit stressed out. She's at work here, but she's not totally at work because she's on the phone with the home care nurse talking about her mom. She's had to reduce her work to half-time because she just can't do everything for her mom and continue to a full-time job. And despite all her and her family's wishes to the contrary, she's now considering putting her mother into a nursing home because she just can't do it anymore. Medicare, by the way, you see at the bottom, has paid over $42,000 for her care in the past year. This is the 20% that spends 80% of the Medicare dollars. This is the population that we are targeting with this new model of care. In a few words, chronic care today is fragmented, discontinuous, hard to access, inefficient, unsafe, and very expensive. This pie chart here shows the total Medicare expenditures broken down according to how many chronic diseases the beneficiary has. So you see that the big red wedge represents the people with 5 or more chronic conditions, spending 68% of Medicare's total expenditures. The gray wedge is people with 4 chronic conditions, another 12% of the Medicare expenditures. If you add that together, this is where you get the figure that people with 4 or more chronic conditions, which constitute a little less than a quarter of the Medicare population, this small subset is spending 80% of the Medicare dollars. So we set out to address this problem. We set out to design a model that would provide better care for people like Mrs. Chen. And we knew that it had not only to improve the quality of care, but that it had to be cost effective. It had to reduce costs because whatever model is invoked has some costs. So we were looking for a model that could pay for itself by reducing expensive care like hospital care and be then a net cost savings to Medicare. We also insisted that this model be diffusible. In other words, some people say, well, it works at Johns Hopkins, but it won't work anywhere else because you have all these special resources. Not so. We built this model so that it would work everywhere in all kinds of practices across the country. And we insisted that practices be accountable so that if they adopted the model, Medicare, and Medicare was paying for this, that Medicare would be able to ascertain that the practice was really doing guided care the way it was designed to be done. So these were all the criteria that we used in designing this model that I'll now describe for you. It's pretty simple, really. It's a specially trained nurse who joins a primary care practice and works with usually 3 or 4 doctors on 50 to 60 of their most complicated older patients. And the nurse and the doctor together are partners in providing high-quality chronic care to this population. So on the surface, fairly straightforward approach. And I want to point out one thing that's really important about this. This model enhances primary care, which is another crisis we have in our country, the decline of primary care and the number of doctors who want to go into it and stay in it. So this is a way to not only improve care for the older person and save money for Medicare, but also to strengthen primary care and bring more doctors into it. So here's what the nurse-doctor team does for these people. I'll go over this quickly and we can get into any more detail that you'd like at the end. We'll have some time for questions and answers. The team does these 8 functions. an assessment. The nurse goes to the patient's home at the beginning of the program and does about a 2-hour assessment of the patient, not only the biomedical diseases and medications and so on, but an assessment of the family caregivers, the environment in which the patient lives, the safety, and the functionality of appliances, whether the house is adapted for the person's disabilities, the nutrition. She looks in the refrigerator and the cupboards, and basically a comprehensive, very structured assessment. Then the nurse takes all this data about the individual person and puts it into the health information technology system. And that then returns to the nurse an evidence-based plan of care, because inside the HIT are embedded the evidence-based guidelines for managing chronic conditions. So they're tailored to the individual, but they're based on scientific evidence of what works best. So what comes out is this comprehensive care plan for how to manage this patient according to the latest scientific evidence. Now that's what we call a care guide. That's written for doctors and nurses and other types of health professionals. So we need a version that's for patients. So we then convert that into what we call an action plan, which is the same information, but it's in patient language. It's written in big font. It uses a lot of graphics. You don't really have to have more than a 6th grade education to read it. And it goes in a plastic jacket and a magnet, and up on the refrigerator or the cupboard at home. Serves as a reminder list of what medicine to take and when, and what to eat and not eat, and what physical activity to participate in, and what self-monitoring, like monitoring one's own weight or blood pressure, and how to interpret those values, what to do if your blood pressure is too high. All this engages the patient in the process of self-management, get them involved in their own care. And once that's established, that action plan is established as a reminder system, the nurse then begins with the monitoring process. So every month, the nurse and the patient have a conversation, often by phone, in which they go over this action plan. They go over each medicine, each dietary, each physical activity, each self-monitoring results. How has your blood pressure been in the past month? And it's a way for the nurse to monitor the patient. And also, when the patient is unable to do some of these tasks, as inevitably, health behavior change is not easy, and people can't just immediately do everything you ask them to do. Then the nurse will use something called motivational interviewing to try to help the patient to overcome her own obstacles and adopt the behaviors that are in her own best interest. Another major function is transitional care. I'm sure you've heard a lot about this lately. The idea of helping, smoothing that process that occurs when patients like this go into the hospital and then go back home or to another post-acute site. This is a very chaotic time in which many patients end up back in the hospital. These unnecessary readmissions occur because patients get home from the hospital with a list of medicines to take. And then they turn to their medicine cabinet and they see a bunch of bottles that have different names on them from what the list shows. And they don't know what to do. Should they take these medicines and these medicines, or only these or only these, or mix and match, what to do, and massive confusion going on. So the nurse, our nurses follow these patients into the hospital, brings the care guide, that all that information that's necessary, gives that to the hospital team, helps plan the discharge, goes home with the patient, smooths out everything at home, makes sure everything that is supposed to be done after the hospitalization does occur, and then gets that patient back to the primary doctor within a week to try to close the loop and make sure that those transitions in and out of the hospital are as smooth and effective as possible. The nurse uses this care guide also to communicate with all other providers. Everyone else that sees this patient will get a care guide, so they'll know the summary of all the information about this patient. Someday this will all be on an electronic database like your banking and your airline information is today, but for now it's on paper. Two other things the nurses do. One is to support the family caregiver, like Mrs. Chen's daughter. Does an assessment of that person, see what she needs and what's available to her, and provides a lot of educational and information, and connecting them with the last item, which is the community services. In all communities, really, there is an array of services that are beneficial to older people and to caregivers. And many times patients don't know about them, or if they know about them, they don't know whether they have access to them or how to access them. Things like Meals on Wheels, adult daycare centers, handicap accessible transportation systems, Diabetes Association, and so on. There's lots of resources out there that people don't know about, and so our nurse connects them up so that they can use these resources and coordinate all those with the rest of the care plan. So that's it. That's 8 big activities that a nurse who has 50 or 60 patients does for all of those patients. It's a big job. I mentioned that it uses an electronic health record to support this. The main functions of that electronic health record, as you see here, are to create that evidence-based care guide. That's really essential to get a good evidence-based plan of action at the very beginning. It also provides a way for the nurse to have a daily reminder of all the things that are due that day for all of her patients. The system also provides some decision support, so all the patients' medicines are entered in one place, regardless of whether they came from primary care, orthopedics, ophthalmology, whoever prescribed it, it's all in one database, and the database checks for possible adverse interactions among those drugs, so that if there are potential adverse interactions, there's an alert generated, and the nurse takes that alert to the physician and says, did you realize that these 2 drugs could kill the patient? And sometimes they say, well, yeah, better stop one of them. Or sometimes they say, no, I think it's worth the risk. The decision of what to do is left to the physician, of course. And finally, this electronic health record serves as a way to document all the interactions that the nurse has with the patients, the families, and the healthcare providers. This is how many of you have seen this before? This is the Ed Wagner chronic care model. Is this something you're familiar with? I won't belabor it if you haven't seen it. I think I'll just skip it. But basically, it's a conceptual model of what we need to do in order to improve chronic care in America. And I just put this up here to illustrate that all the blue are the aspects of guided care that correspond with all the things that this model says have to change. So basically, it's the first model that addresses all the aspects of this change model. And I'm now going to tell you about some of the results of the tests that we've done on this model. Oh, but before that, I'll tell you who's eligible. I've been just saying people like Mrs. Chen, but how do you find those people? How do you decide that they qualify for this care? Because you can't give this kind of care. It's expensive. You can't give it to everybody. So you got to focus it on that 25%. So what we've done so far is to take all the patients in a practice that are over 65, look at their past 12 months of claims data, run it through the HCC. You familiar with HCCs? Medicare's risk adjuster? Not too familiar. Anyway, it's a computer program that takes diagnoses off of the claims of the past year, puts them into a formula, and generates a number that represents that patient's risk of being a high utilizer in the coming year. So we use that system to rank order all the patients from the highest risk to the lowest risk, and then we take the top 25%, and that's the target population that gets guided care. So we've been doing now, we did originally a small pilot study, and that was successful in improving quality and reducing costs. So we used that information in order to get a set of grants from NIH, AHRQ, and the Hartford Foundation to conduct a multi-site randomized trial of this. And 3 of the sites are here in DC and 4 are in Baltimore. We have over 900 patients enrolled in this study. These were patients already established of 49 primary care doctors who were practicing in 14 teams. Each team was usually average about 3 or 4 doctors. So at a typical practice site, say there's one very close to here up at North Capitol, Kaiser, there would be 2 teams. Team A would have 3 or 4 doctors and all their high-risk patients. Team B would have 3 or 4 doctors and all their high-risk patients. And our statistician randomly assigned either Team A or Team B to get the nurse. And the other team and its high-risk older patients served as the comparison or control group. So that's the study design. And we were measuring outcomes at 8 months, and that's, I'm going to show you in a few minutes what the results are. But we also have data from the 20-month follow-up, and we're just now this month completing the 32-month and final interviews for the study. This slide just shows you the characteristics of the people in the study. This is the actual data, and you see it looks a lot like Mrs. Chen, actually. They're, on average, the two groups, the guided care and the comparison group, are shown here, but they're virtually identical. Upper 70s, half black, half white, half male, female, half have high school education, half don't. About a third live alone. They have, on average, 4.3 chronic conditions, have an HCC score of 2. That means that these people are twice as likely as the average to be a high utilizer in the coming year. About a third of them have activities of daily living problems, and some have cognitive impairment, Alzheimer's disease and strokes and that sort of thing. So it's a pretty heterogeneous but sick and disabled population, that 25%. Here are the results. I'm going to give you one slide per outcome now pretty quickly. This slide shows the effects of guided care after the first year, just as it's being rolled out, the effects on physician satisfaction. We surveyed all the physicians in both groups at the baseline before we started, and then a year later, after they'd either experienced guided care or just continued with usual care for a year. And we looked, these numbers represent the difference between the baseline satisfaction level and a year later. So what you see overall is that all these numbers are positive and all these numbers are negative. That means that the guided care doctor's satisfaction with all these domains went up in the first year. And as we're seeing in primary care generally, those doctors who didn't get any intervention, their satisfaction levels went down. And those differences were statistically significant in all of these categories of satisfaction. And this is corroborated by my interviews with all these doctors. Every year I go around and talk to them, and they really, really love working with the guided care nurses. Yes, sir?
In the usual care, is that just a trend line for physicians in general, that every year they're less satisfied, or?
It seems to be. I mean, guided care, primary care doctors are, as you know, are getting very disgruntled. They're leaving the profession, and people aren't going into it because it just has become a less and less attractive and satisfying job. Yeah. We didn't do that. That was just happening kind of in the background in comparison. So the guided care seems to turn that around. Here's the effects on quality of care. We use this scale called the Patient Assessment of Chronic Illness Care. This is a questionnaire that is given to patients, and it asks them, in the past 6 months, how often has your primary care team done this for you? And the this would be something like, talk to you in a way that you understand your problems. How often does your primary care team coordinate your care with specialists? How often do they take your values and preferences into account when making medical decisions? These are the elements that we think are the most important elements of good chronic care. And so we ask the patients, how often do these things happen? So this scale also is broken down into these 5 subscales, but I'm going to skip to the bottom line for time purposes and tell you that in aggregate, across all these scales, this number is the most important one. It's 2.0. It's an adjusted odds ratio, for those of you who remember any of your statistics. What it means is that a patient who has experienced guided care for a year is twice as likely as a patient who has gotten usual care for a year to rate the quality of their care in the highest category. So this is, as you see, very small p-value means it's highly statistically significant difference. Here's a slide showing the effects of guided care after 1 year on the family, the caregivers, like Mrs. Chen's daughter. In particular, these 2 lines up here represent the caregivers who were putting in the most time helping their loved ones, above 2 hours a day. So this line shows you the strain level reported by the caregivers of the usual care patients at the baseline before the study started, and a year later after their loved one had another year of getting older and sicker. So they felt more strained. However, this is the similar group of caregivers of patients who got guided care. Their strain level went down. Just as sick, they got just as old, their strain level went down. They had a nurse that they could call when they needed help, and they worked with. Now, you're all saying this is wonderful. Yes, it's good for patients, it's good for quality, but who's going to pay for it, right? The realities set in. So we wanted to quantify what it costs to operate this system. And it's shown here in our hands in the Baltimore, D.C. area. This is what it costs for a practice to have a guided care nurse, about $96,000 a year. So who's going to pay for that? Well, our hypothesis was that by giving this enhanced care, some of these patients would have fewer needs to go into the hospital, and therefore fewer needs, like Mrs. Chen, to have post-acute rehab and home care and all that. So we looked at the claims, insurance claims for all these patients for the first year, and what we found was summarized in this very dense slide, but I'll walk you through it. This column is the difference between guided care and usual care for 55 patients. 55 is because that's the average caseload of a guided care nurse. So what this means is that a typical group of 55 guided care patients use 76 fewer days in the hospital compared to 55 usual care patients. They used, same 55, had 99 fewer skilled nursing facility days for rehab and 20 fewer home health episodes. That's the whole episode of care. They had 40 more physician visits. So what you see here is a shift toward more outpatient physician visits and fewer expensive inpatient visits. Okay, so you say, what's the dollar figure, right? So we multiplied these differences in the units of service times Medicare's national average payment for each unit of service. So in other words, Medicare's average payment for a hospital day is a little over $1,500, and so on for the other ones. So when you multiply across, you find that there's the cost difference would be about $116,000 fewer just for hospital days saved, and so on. And if you add all the cost difference up, you come to a gross savings of $171,000 per nurse per year. But remember, it's not free, right? You have to pay $96,000 to get that benefit. So you subtract the $96,000 out, and you end up with a bottom line of a net cost savings of $75,000 per nurse per year. And that works out to about $1,365 per patient per year, or about 11% cost reduction, even after accounting for the cost of the nurse herself. Yeah?
Does Medicare pay for the nurse?
Does Medicare pay for the nurse, she says. Not yet. The argument here, however, is that you see, it's the practice that bears the cost of the nurse, and it's the insurer, like Medicare, that reaps the benefit. So the argument naturally flows that Medicare it would be a good business decision for Medicare to transfer funds to that practice to pay for the nurse, and they would still come out ahead. So I'll talk about that a little bit more in a few minutes. Yes, ma'am.
Although the other thing wrong with your accounting is that Medicare doesn't pay a per diem payment for hospital care. In general, it pays on the per admission.
Right.
You probably need to go back and recalculate what the real savings to Medicare would be, not on a per diem basis.
Right. Yeah, we've done it a variety of ways. It doesn't change very much when you put in that they're paying on DRGs, not per day. Yeah, it's bottom line is about the same though.
Yeah,
Yes.
I guess my question on the accounting is why did you do it this way when you have an actual patient pool? Why didn't you look at actual costs?
We had 3 insurers involved here. We had fee-for-service Medicare, Kaiser Permanente, and TRICARE. For one, Kaiser Permanente is proprietary, and they wouldn't give us their actual costs, but they would give us the claims that showed the units of service used. So that's why we had to base everything on unit of service and then do the multiplication. And I know that these numbers look small, actually, if you're familiar with what Medicare actually pays. It's $1,500 sounds awfully low to me, and so does $41 for a physician visit. These are just for example, and probably the savings are actually greater if you used real dollars paid rather than posted national average for the whole population, because these are high-risk people. So anyway, it's not proof, but it's very encouraging that this model seems to have some economic viability in that it actually saves more than it costs. What do nurses say? We surveyed our nurses to see if they like this job, because obviously if they don't, then the model doesn't have a future either. These are just some of their comments. And I'll show you some data in a minute. So the nurses love it. All 7 of our nurses are very positive about this. That this is what I went into nursing for in the first place.
How much paperwork did they have to do? I mean, once the guides, the action plan and the guide were done for a given patient, how much actual paperwork?
There's not much paperwork involved. We have this health information technology, and so when they would have an interaction, they would enter it into the computer. I mean, they would keep records like any health professional would, but there's nothing particularly extra about it. So, summary of the early results is that it clearly improves the quality of care. It reduces net expenditures for care. And we found out in implementing this at 7 sites in this area that it's fairly easy and quick to implement, and it's very popular with all the participants, the doctors, nurses, patients, caregivers, and so on. So it seems to be something that should be considered in thinking about healthcare reform. And we are thinking about that. Our future directions with this model are we're hoping that, we'll enlist maybe some of you, we're hoping to get a national pilot program of guided care as a part of healthcare reform package. We're looking for champion legislators that might want to be interested in this, and if any of you are interested, you should talk to Tracy Novak here, who's my communications director. She's organizing folks around this issue. We're also providing these forms of technical assistance to try to facilitate the uptake of guided care. Obviously, there has to be a payment source, or it's not going to be adopted by practices. But if there were a payment source, then we're providing a book, which is this one you saw before. This is Guided Care. It's an implementation manual. It provides lots of very practical information about how you go from a current practice today to a guided care practice, how you find a nurse, hire a nurse, integrate the nurse into the practice, manage the nurse, communicate with the patients about the nurse. It's very practical. We've also developed an online course that prepares nurses for this role. Same course we delivered for our nurses. We've now put it online, and that course is actually, the first one online began this week. At the end of it, if the nurse passes the online exam, she gets a certificate of guided care nursing, which is offered by the American Nurses Association. So it's a prestigious sort of a job qualification. We also have an online course for physicians to prepare them to work in this kind of an environment, as well as guidance for practices in selecting health information technology that would be needed to support the guided care model. Later this year, we hope, as a part of the Medicare medical home demonstration, we're going to be providing learning collaboratives. These are weekend workshops around the country where practices can come and hear presentations about how you adopt the medical home and guided care and interact with practice change experts that will help them to change their practices. And if that's not enough, then we will also be providing individual consultation to organizations and individual practices. I just want to acknowledge again the wonderful grant support that we've gotten from this work from AHRQ and NIA, and the Hartford Foundation, and the Langeloth Foundation. I guess we have a few minutes now to, here in case you're interested in the published work that reports the details of these figures that I've been showing you. These are the published articles. And the book is the second to last one. And if you'd like to follow the progress, we post everything, all the current developments on our website called www.guidedcare.org. Lots of information on there. So let me stop there and see if you have any questions. Yes?
I realize that at the end of a test like this, the physicians are very happy with it, but have you encountered reluctance on the part of physicians to participate in this because it sort of consolidates power or consolidates information and knowledge in someone who's not a physician?
Good question. Good question. It's about, everybody here, resistance among physicians. I must say, when I first was recruiting these 49 doctors to be in the study, they were skeptical on average. They weren't so sure about this, and I think one of the issues is the threat to changing the practice model? Are we going to allow a nurse to kind of supplant some of the physician? They were worried about time, mostly, even more than that, they were worried about effect on their time. They're stretched so thinly now that they worried that even, I mean, I went to them and said, look, I'll give you a free nurse that'll help you with your most difficult patients for 3 years, and you can quit after a year if you don't like it. And they were still skeptical because they worried that it was going to take time. They had to talk to the nurse, right? And where's the time for that? There might be paperwork, and they've already drowning in paperwork. So these are the realities of any change that you suggest to a primary care doctor today. But they all did it, and after a year, they began to warm, and after 3 years, they are all, 100% of them, totally committed to this model. So that's why we surveyed them. We knew that we needed the voices of real physicians to tell other physicians that if you just try this, you'll love it. And they all did not want to lose their nurse at the end of the study. In fact, 6 of our 7 nurses are continuing at the end. Our study ends this month. And the 2 managed care organizations that we dealt with, Kaiser and TRICARE, or USFHP, both adopted the model at the end of the study. So even though we're done at the end of this month, they're paying the full cost of these nurses. They think it's a good business decision in their interest to continue this model. So our next audience, of course, is CMS, and we want them to believe that it's in their best interest as well. So, yes?
Was the caseload of 50 or 60 patients per nurse, I guess you kind of approached that from the top, from the bottom, and figured out, I mean, it sounds like an awful lot of people to be essentially doing what the doctor's trying to do for every single one of them with better knowledge. So this is really something that a nurse can deal with in the course of a month?
Yeah, we actually surveyed the nurses just 2 months ago. At the end, they'd been doing it now for 3 years. And we asked them a couple of questions about that. We asked them how much of the time they felt overwhelmed or stressed by the workload. And they generally did not feel that way. They felt that there were days that you know, all hell breaks loose and you know, they just can't do it all. And we've given them priorities to help them to say, when you can't do it all, here are the most important things. But by and large, they like their jobs, and they did not feel like it was too large a caseload.
If a practice, if any given primary care person's practice had an overload of patients in this category, then you have cut off the top 25, and yet there are other people with needs. Is there any such thing as partial guided care?
Yeah, you know, I think that there will be in the future. For people with lower need, lower risk, is that what you're referring to?
Yes, or even ones that are, if a practice has got a whole load of really needy people.
Let me clarify. I know what you're saying. What we would advocate for the future is that there be a set HCC score. So if a practice had an especially large number of really sick older people, it wouldn't just be the top 25% of their practice. It would be everybody in their practice with an HCC score above a certain number. That's based on the national average of what 25% would be.
2 nurses or 2.5 nurses.
They could, absolutely. The ratio, yeah, 2.5, but the ratio would probably be in the 60 patients per nurse. And as they got to 120, then they would want to hire a second nurse, yeah. Yes.
Is there a possibility of extending this to non-gerontology situations? You know, the families that have children that need so many different services
Right.
or so much different care. I mean, this sounds like that would be a wonderful.
It does, and we studied this in the older population mainly because we were able to get access to Medicare patients. But the same principles, I think that's what you're getting at, the same principles, the same needs are experienced by younger people, whether they're children or middle-aged people, people with, say, kidney failure on dialysis, people with HIV/AIDS, people with complicated problems could benefit from this probably. We don't have data on it because we only studied the older people. But in reality, I think probably that would be very helpful, and you probably get similar results in younger population as long as they have the multiple chronic conditions and the complex needs.
Are you looking at kind of doing that as your next step once you get this kind of taken care of, or somebody else is going to have to figure it out, or what?
We don't really have any plans right now. Our focus, as I mentioned earlier, is to try to get this available to the older population who has through the Medicare program. But it's certainly wide open for others to apply it to younger, complex problem patients. Yes?
This is kind of on the edge, but how big an area did the nurses have to cover physically?
Mm-hmm.
Because if you live in a place like Washington, D.C. or Baltimore or, you know, name a place where the traffic is terrible, if they're running from Fairfax County to, you know, Baltimore City, that's pretty time-consuming, I would think.
Yeah.
I'm recognizing, of course, they're not seeing patients, you know, on a regular basis, but.
Right. Well, the fact that the nurse is located in a practice, basically the nurse covered patients of that practice, and they tend to be aggregated. I mean, people sort themselves out according to where they go for care. There could have, you know, there could be the odd patient who lives, you know, far away, and that presents a challenge. But by and large, our nurses didn't have to exclude anybody because they were able to service them all.
Following on that question was something that made me think about the rural areas where, you know, going from one doctor to another can take, you know, 30 to 40 to 50 minutes, depending on, you know, how cold the place is. Have you tried this model in those types, in that type of environment, or has it just been a city experiment?
We've had, and we haven't really, we didn't design this. Our study was done really in urban and suburban areas. So we have not been out west, for instance, or in areas where it's really dispersed. I think the answer to this, though, is to have probably one nurse divided between, say, two practices and split time between them. I worry about splitting the nurse between too many or among too many practices, because then they don't develop that teamwork with the doctors. But probably we did have one nurse who had one of the doctors in one of our practices left the practice and moved 10 miles away. And so many of that doctor's patients went with the doctor. So our nurse then had most of her patients at one site and a handful of them over at this other site. And that just happened during the middle of the study. So we said, well, let's try it. Go ahead and keep working with the doctor and keep working with the patients. And she did. And it didn't seem to be any problem because they'd already established the rapport.
And at what level of the nurses? Are they nurse practitioners?
No, these are RNs. They're not advanced practice or nurse practitioners. And they're not LPNs. We very carefully considered all the options about what level of nurse, considering things like available labor pool, skill level, and kind of match that up with the various tasks of the role. And I think our judgment at the beginning that is that it should be an RN level was borne out by experience. I'm convinced that a nurse with less training, such as an LPN or aide or so on, cannot do this role. The patients are too complicated. There's too much biomedical interactions with other healthcare professionals for a person that does not have an RN. On the other hand, advanced practice nurses would be great in this role, but you have a real problem with the labor pool, the available labor pool. We're talking about this as a national standard of care, and there just aren't that many. And a lot of people are going into nurse practitioners, but becoming them, but there isn't going to be a labor pool sufficient to staff this. There's an enormous labor pool of RNs, and I don't know if you know this, but 500,000 registered nurses are holding current active licenses to be RNs and are choosing not to be in the workforce. 500,000 for various reasons. Disenchantment, some of them stop to have their families, different reasons. But those, we believe, can be lured out of semi-retirement to go into this kind of work because nurses love this kind of work. And in our study, the nurses that applied for, we didn't stock the study, by the way, with, ace nurses from Johns Hopkins Nursing School. We didn't do that. We wanted this thing to be studied the way it would be practiced in the real world. So we just advertised in the paper, and we took applicants, and we hired the best we could get. We didn't offer particularly high salaries, just market rates. What we found was that the average age of our nurses was 45. But we had quite a range. We had some that were, one of them who had just 3 years out of nursing school, had never done anything but hospital nursing. We had one who was a 20 years psychiatric nurse doing counseling. We had a couple that had been case managers. We've been people that had worked for disease management companies. So a wide variety of people. They all were able to do this job. Yes?
You said that of the 3 groups of doctors that you picked, the ones from the Kaiser and the TRICARE groups wanted to adopt this.
Yes.
But the private practice people couldn't, I guess, because even though it's a benefit to Medicare and to the patient, it would be a losing thing for them because they have to do,
That's right.
well, pay for the nurse and then also do more doctor visits, right? So it's more work for them.
Well, for the practice that was fully fee-for-service, there was one other practice that had no managed care in it, and it was the one that did not continue the project. Well, it won't continue at the end of this month.
Even if they thought it was a good idea for
Yeah, they can't bear a $96,000 outlay every year without any returns. And none of these services are billable to Medicare.
I mean,
Yeah,
that's
right.
what you're hoping is to show.
Exactly.
But then once it's billable, then there'll be all kinds of paperwork to justify every single phone call.
Oh, I certainly hope not. I absolutely capitate this. This should be, if you're familiar with the Medicare medical home demo, we're talking about a sort of a 3-tier reimbursement system. The first tier would be continuation of fee-for-service as it is now and all its paperwork and codes and so on. Not changing that at all, but then layering on top of that a monthly care management fee. It's risk adjusted, so more money when the patients are particularly high risk and less when they're less. And on top of that, a pay for performance bonus, so that if the practice and the doctor are able to deliver really high quality care, they can earn a bonus. Yeah, you're welcome. Yes, ma'am.
Were the patients in the study primarily community dwelling, older?
They were all community dwelling.
They were all community dwelling. And what percentage were low income or of the Medicare beneficiaries were dual eligible?
Well, let's see. Kaiser categorically excludes Medicaid, so there were none in Kaiser. The others, which was about 60% of the patient population, there was no distinction made about whether they were on Medicaid or not. So with the average being about 18% of Medicare beneficiaries are also dually eligible for Medicaid, it's about that. So basically it was only determined by their HCC score, whether they were eligible or not.
Hi, the Aging Network provides a lot of programs for community dwellers that are more social service oriented than healthcare oriented, like family caregiver support, meals programs and programs like that. How do you see the guided care model linking to the Aging Network and helping to serve citizens?
Right. Everybody hear that? All these community services, which sometimes are referred to collectively as the Aging Network, how do we link guided care with that network? It's really, I think, a bi-directional link. Our nurses, part of their initial orientation to their practice was to go to the area agency on aging, the AAA they call them. There's one in every region of the country where it's a clearinghouse, a kind of a coordinating center for aging-related services in that community. So our nurses go there as part of their orientation, and they find out, they get the name of somebody, they get the website, they get all the brochures, they learn about all the services that are available in that community. And I know in the future, a parallel system will be the Aging Disability Resource Center, ADRCs. Those will be similar, and so our nurses would need to become acquainted with a person, a website, and all the information, so that the nurses can make appropriate referrals to these, either to the AAA or the ADRC or the direct services themselves. And on the other end, we'd want the Aging Network providers to know about guided care, where they could make referrals. So if a patient is just not getting this kind of holistic, good, continuous chronic care, they could say, well, did you know that over at this practice, they have guided care, for instance, and you could get that over there. So we see it as really important to develop communications between the guided care nurse and both of these networks.
Did you see a change in referral pattern during the trial that people would acquire new patients who needed this kind of care? Or were the number of patients fixed at the beginning of the trial?
I didn't hear the first part of what you said. Did we
You
see
said
what?
that, the nurses went out and made liaisons, so that what you might have expected to draw new patients into the practice, or were the number of patients fixed at the beginning of the trial?
Well, the total caseload was fixed. We put it between 50 and 60, but and the only way people get discharged from this is an important difference. It's not like case management where people are in it for a while and then they're discharged. Once a nurse picks up a patient, they never get over their chronic conditions or their complex needs, so they're in it for life. But realize too, these are quite sick people, and so there is approximately a 10% mortality rate in this population. So, and people occasionally move away to live with their kids or something. So as people transition out of the practice, then the nurse could take on more. So there was a certain turnover, but not a whole lot actually. Yes?
So the patient, both the patient and the nurse have a choice whether they're compatible with each other?
Not really. I mean, you can't force the service on the patient.
Yeah, because sometimes, for no reason you just dislike somebody, and it's no point if you've got a couple, the patient and the nurse, and they cannot get along.
Right. So patients always have the option of declining services, as they would with a physician. They don't have to go back. They can tell the nurse, I really don't want to do this anymore, and they can stop. The nurses are health professionals, and unless there's some really unusual, we did have one unusual circumstance, but we don't usually ask them, just tell me which patients you like and which ones you don't like. We had one, for instance, with the patient, or the nurse went to do the home visit and found it was an elderly gentleman. It was the patient, and when the nurse arrived, he was in the bedroom, and there was a scantily clad middle-aged man waiting to greet her, who didn't really want her to talk to his dad. He just wanted to sit there with his legs up on the table and talk to the nurse, and she was very uneasy, and so we had to, basically intervene and say, this is not going to work.
Can they fire patients? Because I know I have friends in an endocrinology practice, and if their patients aren't following the guidelines that they set forth for a diabetic, let's say, and they're consistently just not doing more harm to themselves than doing good, they'll discharge that patient from their care. Is that an option in here?
Right. Well, this is the question about patients who are just non-adherent. They're just not interested. They don't want to take care of themselves or follow advice or anything. We really don't offer that as an option. We just try to keep working with them because you don't have to knock your head against the wall, but you say, okay, I understand you're not interested in this now, but I'm going to call you back in a month or two. I'm just going to keep the door open, because you know what happens? These people, they get wake-up calls. These are sick people, and they have a heart attack, or they have a stroke, or they break their hip. And suddenly they feel very vulnerable, and you have these sort of foxhole conversions, and they say, oh my God, I've got to stop smoking now, and whatever it is that's their behavior change. So we never fire them. We never discharge them. They can discharge themselves if they want. But we just try to keep the door open, and we don't waste a lot of time or antagonize people by harassing them if they're not interested. Well, I guess we're right about on time, so thank you very much. Appreciate it. We have, I think you all got handouts that's summarizing guided care and our proposal for a national pilot. And if anyone is interested in the article by Leff, that's the one that shows the cost savings. Tracy has 15 or so copies that she could pass out if you'd like to see the source article. Otherwise, these are all available online as well. So thank you very much.